Hi everybody, Dr. Britt Talley Daniel MD, a neurologist and headache doctor. And I'm dictating another YouTube video on a subject called fast migraine treatment, but I really mean by that statement acute therapy for migraine. And you can find an article about that on my webpage at drmigraine.com. To start it off, I want to read out of chapter 10 in my big textbook on migraine. It's published on Amazon. I want to go to chapter 10, and what this is like much of the book. I've written a series of interviews between a patient and a doctor, which happened like in a neurologist's office. And this is what I'm going to read, this dialogue, hopefully make a teaching point, which I've worked on for years in patients of my own. Okay, acute therapy for migraine. So the patient settled down in her seat before she said, "This Maxall drug is not working, at least for my last 2 migraines. I think I want to try something else." Well, we'll talk about that. The migraines lasted all day, the young lady said. "I had to go home from work." The doctor watched her readjust her position and gaze up from her headache diary, which she was using as a reference. "Well, when was the last migraine?" the doctor asked. "What day was it?" The woman looked down at her calendar, marked the day with her finger, and then looked up. "Last Friday, June 29th. "Now, what time did it start?" the doctor asked. "Just afternoon, about 1:15 p.m., she said. "And you felt well that morning when you woke up?" the doctor said. "Yes," the patient said. "And you ate breakfast and lunch. You didn't miss a meal, did you?" he said. "Well, I was late at getting up, and I left home without eating, so I had a cup of coffee and a bagel mid-morning," she said. "And I suppose you didn't eat lunch either?" the doctor asked. He watched her purse her lips together and shake her head no. "No, I ate brunch. I wasn't hungry." "Okay, so the headache started at 1:15. What time did you take the Maxall?" the doctor asked. "Well, I wasn't sure it was a migraine when it started," she said, "and sometimes they're not that bad, and Advil will get rid of them." "So you took Advil first?" "Huh?" the doctor said. "Yes. And what time was that?" the doctor wanted to know. "Well, I had an interview about then. I had to leave for my office, so I guess it was about 3 o'clock. "You took Advil at 3 o'clock. Did that help?" the doctor asked. "No, not much. It just kept getting worse, and I had to deal with it," the patient said. "Well, then what time did you take Maxall?" the patient wondered. The doctor wondered. "Well, I felt so bad later in the afternoon. I got nauseated, afraid I would vomit at the office around all my coworkers. So I didn't take anything until I got home. That was about 6:30, the patient explained. "I see," the doctor said. "Your migraine started at 1:15. You waited, you took nothing. Then you took Advil after an hour and a half, but that didn't do anything. And so you finally took Maxall 5 hours later." "Yes," the patient replied. The doctor looked at her sympathetically and said, "You are supposed to treat your migraine at onset when they're early and mild. But in the situation we just discussed, Maxall didn't work because you waited. You need to retry it and treat at the beginning, at the onset." Wow, have I talked about that a million times in my office to headache patients. So if patients would do that, they would have better treatment for migraine. So migraine occurs in 12% of the American population, and 25% of women and 6% of men have migraine. It's the 5th most common cause of disability and the 10th most common cause of a visit to the emergency room. And the 3 most painful conditions known to men are kidney stone, childbirth, which men will never go through, and migraine headache. So how do you get fast migraine headache or really effective acute migraine therapy? Question mark. Migraine headache should be treated at the onset of the headache pain with a triptan, period. This is advice for fast, effective, proven neurologic headache treatment for migraine. Migraine headaches have 4 phases. There's a prodrome, it's usually the day before, the aura, if patients have aura, the attack, and then postdrome. And the deal there is something like 30% of headaches are migraine, 70% of headaches are tension type headache, and less than 1% of headaches anyone has are something other than those 2. And the most common headache type is tension type headache, which relates to the anxiety disorders like generalized anxiety disorder. And most people, in my experience, don't come see the doctor unless they get into trouble with overtreating or medication over his headache. Okay, so also something like 30% of patients who have migraine will have migraine with aura, which is usually a visual event. There can be trouble with numbness on one side of the face and hand, and also trouble talking. And then 70% of patients just have what's called migraine without aura. And then afterwards, the next day, they have what's called a postdrome. They'll have an achy head, they don't feel well, they go to work, they're not functioning very well, but they try to get back in their lives. So the patient should treat at the prodrome if they can determine what that is, or at the onset of the aura, if it happens then, if they have aura, and then if not, at the onset of the headache attack. And treatment should be one of the fast-acting triptan drugs. Okay, the prodrome may come 24 hours before the attack occurs. It may consist of fatigue, drowsiness, food cravings, depression, irritability, trouble concentrating, phonophobia, sound sensitivity, and increased urination or diarrhea. Those all can be symptoms. The patient, if it happens several times before a migraine comes, I get the point, that's what your prodrome is, and you can treat then at the onset. So if the patient can recognize those symptoms and the reliable occurring symptoms that happen before a headache starts, then they should treat at prodrome. That might be a day before the headache starts with a triptan. We had a migraine with aura patient with a visual aura before the headache starts, and they should treat at the beginning of the aura, which sometimes it may come 10 or 20 minutes, up to an hour before the headache starts. But sometimes the aura comes simultaneously with the headache when it comes on. That is, headache and aura come together at the same time, or it may come in the middle of a migraine or at the end of a migraine. In that situation, the patient would have treated at the onset of the headache. Now, only migraine headache patients have this altered brain neurophysiology, which leads to the headache, so that 94% of men and 75% of women who don't have migraine don't have these changes. Only migraine patients do this. So the migraine process releases 3 neurochemicals in the brain, which cause the problems. The problems are caused by neurokinin A, substance P, and CGRP. These are chemicals that cause arterial dilatation, inflammation of the trigeminal nerve, and the arteries, and then the thalamus. So if you take one of these triptan drugs, and there's 7 of them early on in the onset of a headache, it'll stop the process of the migraine. One of the headache would start, would just start in the headache, and then stage 2 is 20 to 40 minutes into the headache. So if someone starts with a headache at 8 o'clock, by 8:20 or 8:40, they're already at stage 2 when the neurochemicals come out and they start causing arterial dilatation, which is stage 3. And then stage 4 comes about 3 to 4 hours into a headache, which would be in this schema, 11 or 12 o'clock or something like that. And at that time, the thalamus, which is the pain center deep inside the brain, is inflamed, and the headache's much worse and lasts longer. So if you treat early at stage 1, like at 8 o'clock, or at prodrome, as we were mentioning earlier, then something like 80% of patients are headache-free in 2 hours, and there's no drugs yet that will do anything like that. Over-the-counter drugs don't do this, they're just mild painkillers. That's why triptans, which came out in 1991 as injectable Imitrex 6 milligrams subcutaneously, have been so successful. It really changed the history of migraine in the world, really. Okay, so triptan rules. Well, you shouldn't use them with a strong family history of coronary artery disease or stroke or untreated, uncontrolled hypertension. You should limit it in people who have over 65 years old. You kind of drop the dose there. Anybody who's had complicated migraine, aura type symptoms that last over an hour, probably not use triptans. You're not supposed to mix the triptans or take with ergotamine, which is an old type of migraine drug, not being used much anymore, within 24 hours. And triptans themselves, although they're something like 80% successful at treated early on in the migraine attack, they still may have some side effects. And those are typically tightness in the chest or in the neck area. Patients can nearly faint. They may have neck or back pain, which can be burning or feels warm or hot, or dizziness or drowsiness. The tightness is what really bothers a lot of folks because they think it's something like angina or something. And I explain this. Really, migraine causes your arteries to dilate, and the drugs we use for constriction, like triptans, cause vasoconstriction. And so that's just tightness in the esophagus, the tracheal muscles inside the neck. And that's also a dose-related type of side effect. So if you drop the dose, like if you're using 100 milligrams of sumatriptan tablet, you drop it to 50, usually hopefully you'll get rid of the headache, but it won't cause the side effects. If not, switching to another triptan, so if you're taking one, you get 6 other choices of triptan you can take. Something like 60% of the time is effective in treating the headache patient. And so I'm just going to list these triptan drugs on my webpage about this. It's listed as fast migraine treatment. This is all written up. So there's Imitrex, which is sumatriptan, Zomig, which is zolmitriptan, Maxalt, which is rizatriptan, Relpax, which is elatriptan, Emerge, which is naratriptan, and Frova, which is frovatriptan. And all these drugs have gone generic now. Now, the shortest onset drug is the injectable Imitrex, or the nasal spray Imitrex, which goes in 10 minutes. If you take oral sumatriptan or Imitrex tablets, 200 milligrams, it takes 30 minutes to get onset in the brain. The other thing one can try is Zomig. Zomitriptan has a 5 milligram nasal spray, works in 10 minutes, and I have no data on the concentration in the brain, but the American Academy of Neurology headache group has published a statement which I say to patients, and I'll say here, on sumatriptan drugs. So if you take sumatriptan injectable 6 milligrams subcutaneous shot, it works in 10 minutes and gives a level of medicine in your brain of 100 milligrams. If you take the tablet on generic sumatriptan, 100 milligrams, it works in 30 minutes and gives a level in the brain of 30 milligrams. And then if you take the nasal spray, also works quickly, 10 and 25 milligrams, it works in 10 minutes, but gives a low level of 10 milligrams in your brain. So nasal spray is just like the Zomig. Nasal spray gives low levels of medication, whereas the makers of sumatriptan, which is Glaxo in the early 90s when they brought it out, they knew the best drugs. They brought it out as an injectable drug. And again, these drugs taken at onset block the release of these new chemicals that cause all the problems with migraine. So the patient really only has about 20-40 minutes acutely to treat. Okay, next we're going to ask a series of questions. First one would be, why don't patients treat their migraines early on with a triptan? Good question. We just heard about it in that story I told you. Hoarding. Patients only get a limited supply of drugs every month and they don't want to run out. I've got to save them. It's the end of the month. I've only got one Maxalt left. Insurance companies limit sumatriptan tablets to only 9 per month for many insurance companies. And some of them only give 2 triptans per week, so the patient has to go back to the drugstore to get their medicines again. One study found that 37% of patients with insurance plans that limited the number of triptans per month did not treat their headaches with a triptan, and they had more ER visits for headache per year than patients without insurance who are more likely to take their medicine at the onset of a headache. Well, the other thing is they're expensive. They're not as bad as they used to be. There now may be a copay of one of the triptans of $10 to $40 per prescription, which can add up to the patients taking several other drugs. However, all the triptans now are generic, they're cheaper than name brand. Sometimes you can find coupons online that'll help you get a better deal. Or visit with your friendly neurologist's office. If you had a guy, they have samples in the office. You look at them, they can give them out. We don't have generic samples, we have name brand samples of some of the drugs. Number 3, nihilism. Nothing works for treatment of migraine. Many migraine patients have ingrained previous experience that nothing will work. These are the migraine patients who have been using over-the-counter meds, opiate narcotics, butalbital drugs for years, and develop medication of his headache, and triptans, and nothing really will work in that situation. You have to educate the patient, get off those drugs, and some clearance time in the brain, a month or 2 or something, and then you can use a triptan and it'll work. The only thing that'll work in that situation is DHE, dihydroergotamine, which can be taken as an intramuscular shot or a nasal spray as Migrainol. I've got an article on this on my webpage on medication overuse headache, if you'll go check that out and read about it. And when many patients who've been taking a triptan, like the patient in the discussion who was taking their Maxalt late, and how to do it. 4, fear of overtreatment. I don't want to take too much medicine, the patients will say. Experienced migraine patients know if they take too much medicine, it's like a snake on the ground that you bash on the head, it'll rise up and bite you on the leg. Sometimes it results, if you take too much headache medicine, in more headaches. So you're only supposed to treat headache, migraine patients only treat headache, or generally for any medical problem, more than chemicals, drugs, more than 2 days a week. So there's a 2. That includes caffeine, over-the-counter drugs like NSAIDs, like Advil, Aleve, and also Tylenol, and certainly opiates and butalbital drugs. No migraine patient should really ever take that. There's no reason to do that, and they have all kinds of problems. And you're supposed to limit triptans also to only 2 days a week. Lawrence Newman, who's the director of Headache Institute at St. Louis Roosevelt Hospital Center in New York, was in an interview several years ago, and he was asked the following question: if you had a single piece of advice you could give to every headache professional treating patients with episodic migraines to ensure their patient with migraine would progress to chronic daily headache, what would it be? And Newman's response was, quote, to limit the number of acute medications they're giving at one time, not be too liberal with refills, so that you keep a close watch of how many medications patients are using and initiate preventive treatment in appropriate patients. If you do that, you can proactively, in many patients, prevent medication use, headache, and the progression of the disorder. Number 5, concern for side effects. The triptan treats the migraine. The patient tends and dreads the side effects, the chest tightness, the neck pressure, the fainting, drowsiness, and all that. This is where the treating doctor should really reassure the patient that the triptan side effects are not serious. And many patients hearing that will gladly tolerate a mild side effect for this miraculous drug that usually treats migraine. And also they can find that their side effects are dose-related and drop the drug, as we said before. American Academy of Neurology has said the best triptan is clearly injectable 6 milligram 91. Now, migraine patients who fail to respond to one triptan, like sumatriptan, may respond to another triptan, like zolmitriptan, 60% of the time. And we do have these two new drugs that are out there, GPENs, that just came out in December 2019, another one in January 20. And they're just out, and we don't really have any data effectively on the use of them. To read about them, they sound less effective than triptans, but they could be useful drugs for a side effect profile. So the patient could take it who have triptan side effect profile. And they're supposed to be released and okay for patients who have coronary artery disease. All right, number 6, waiting. We heard about that with the patient in the story. I just want to wait and see if the headache would go away. I wasn't sure it was a migraine. So they go away on their own. I was just waiting to see if it was going to be one of those, and it usually is. This is the old, I want to wait and see. They wait and they lose. Migraine sufferers should consider that patients who take a triptan early at onset, about 80% of them are headache-free in 2 hours. Dalhoff and Mellberg from the Gothenburg Migraine Clinic in Sweden were quoted in neurology reviews in 2007 as finding a substantial difference in total pain in early versus late treatment with triptans. They found the difference was greatest with oral triptan treatment as compared with injections and nasal sprays, and that early treatment has substantial impact on pain, aura, nausea, sensitivity to light and sound. Overall, the total pain during the 72-hour follow-up period, they said, was lower after early treatment. So, the guys get the point here. You got to treat early. Many articles have shown that works. Number 7, another reason for not treating with a triptan early on. The patient ignores their nighttime migraines. I woke up at 4 in the morning with a headache. What can you do? I just rolled over and went back to sleep, but I had a terrible wake-up headache in the morning. This is the nocturnal migraine coming at the end of a REM event or a dream at night. Many patients with headaches like this wake up in the morning. They call it a wake-up headache when the migraine is still there. They're already at stage 4 in this migraine thing where the thalamus is turned on, and triptans don't work well then. So these early morning wake-up migraine headaches, nocturnal headaches, last all day and sometimes into the next. These patients should be instructed to sleep with their triptan pill open and available on the table next to them with a glass of water next to them, so they can sit up, take their medicine, swallow it, and then go back to sleep. Also, injectable sumatriptan or nasal sumatriptan or zolmitriptan may help nocturnal headaches because they work in about 10 minutes. This is how to treat nighttime headaches at the onset when they're early and mild. Number 8, excuses. I've heard this, all these. I was at work, I left my medicine at home. It was like that student was leaving their homework at home, the dog ate my headache. headache medicine. I was in the middle of an important meeting. I was driving to work in traffic. It rained, the freeway blacked up. I had a deadline project to finish that day. I couldn't do anything else. I couldn't even eat lunch. These are patients who have faced the reality of life. Migraine is a special genetic problem they have, and it's a chronic problem. It's part of their genome. It's probably in their family. The possibility of getting a migraine is always there, particularly if there are aggravating features like stress, menstruation for women who react to that, barometric pressure change, skipped meals, not sleeping well, and all that kind of thing. The Boy Scout motto is, be prepared, and migraine patients need to be Eagle Scouts. The patient tends to have their medicine, which should have them with them at all times. An attack could come at any time. Get a grip. Treat with a triptan early at onset when mild. 9. Patients are not well informed. They have never been told how wonderful triptans are if you take them early on, how they've changed the practice of medicine. And the facts are that 67% of migraine patients have been given a triptan by their doctor. Wow. So they're not given out well. Triptans have been around for 28 years now, and they're not new or unknown. The majority of patients are first seen and treated by their family practice or internal medicine doctors, and that's where the drug should be tried. Treatments with triptans should start with the primary doctor, and many times it doesn't. All right. So this is ended my discussion on fast treatment of migraine or acute therapy for migraine. God bless all you patients with migraine. I hope this helps you with your treatment. Be sure to discuss all these issues with your doctor. God bless you. I'll see you again on another talk.